All right. Well, of course, it's our July 2022 UCCCN meeting. And we're very, very pleased that you guys are with us and hope that a lot more will be joining us in a minute. We're going to start with our usual introductions. And again, a few people might get skipped in that today, but we will make sure that we know who they are because of our registration process. And that's kind of a good and bad thing today. Then our agenda will include our usual announcements and any updates, our brainstorming time, which is when people get to share things, good, bad, and other. And then we're very excited, of course, to have our mental and behavioral health focused meeting today. And we'll be talking about 3 different programs. And we'll also be talking about a number of other sort of related things, including a survey that we did last year that we want to do again and see if things have changed at all there. And then kind of talk about the survey topics with regard to our presentations today. So we're excited about that as well. So let's start with our welcome into introductions. So again, welcome everyone. I am Mindy Tueller. I am the Director of Operations for the Medical Home Portal. And I facilitate this meeting, the Utah Children's Care Coordination Network. And I'm so happy about that. This is one of the really high points of my job. I love this part of it. So I'm going to just take a look at the participants that I can see, and we'll just go down in the order that I've got them on my little thing. So I see Michelle next. So Michelle, would you tell us who you are?
Yes, hi, I'm Michelle Redfield. I'm the Administrative Assistant for the Medical Home Portal, UCCCN, and General Pediatrics.
And she's indispensable. Eric.
Good morning. My name is Eric Christensen. I am the Program Manager with Integrated Services Program with Utah Department of Health and Human Services.
You got that right. Good job. And Gabby.
Yeah, good morning. My name is Gabby Baragoshi, and I'm a quality improvement specialist at UPIC and have worked with you probably in the past already at least once.
Happy you're here, Gabby. And Amy.
Good morning. I'm Amy Nance. I am the new office director for the Office of Children with Special Healthcare Needs within our new merged Department of Health and Human Services. So I'm taking Noelle's position. She's stepped up to the division director. So thank you. This is the first time I've joined this meeting.
We're really happy to have you here, Amy. And of course, Amy has been involved in related programs for many, many years, and she's got lots and lots of wonderful experience and know-how. So.
Thanks, Mindy.
All right, and Athena.
Hi, I'm Athena Parker. I'm the Support Services Manager with the Medical Home Portal.
Wonderful. And Dora?
Morning, everyone. My name is Dora. I am the Professional Relations Coordinator for Shriners Children's in Salt Lake City.
Welcome, Dora. It's nice to see you.
Thank you.
And let's see, I've got Angie next.
Hi, this is Angie Richens from Alpine Pediatrics. I'm the Director of Behavioral Health and Case Management here.
We're really happy you can join us this meeting, Angie.
Okay, thanks so much.
All right, and next, let's go to Erica Wall.
Hey, I'm Erica Wall. I'm with Eric's team, ISP Services for, what are we called now? Department of Health and Human Services, I think. I cover Duchesne, Daggett, and UNA counties.
Fantastic, wonderful. All right, and Gwen.
Hello, I work for Eric's team with the Integrated Services Program, and I cover Carbon, Emory, and Grand. And I had a visitor, so I'm not sure if there were other instructions because I was chatting. So thanks for having me.
No other instructions at this time.
Score.
Glad you're with us, Gwen. And Heather.
Hey, good morning. I'm Heather Carlson. I'm a nurse care coordinator for Eric's team up in Northern Utah, Integrated Services Program.
the one and only. And Heidi.
Hi, I am Heidi. I'm also, I work with Gabby in UPIC. I am a QI coach there.
So glad you're with us today, Heidi. And Julie Southwick.
Hi, this is Julie. I am a transition specialist with Eric's team with the Integrated Services Program. And I also work with Amy for the Utah Birth Defect Network as a health educator.
Julie wears a lot of hats, very well. I'm delighted to see Leah on our participant list.
Hi there, I'm Leah Colburn with the Department of Health and Human Services, Office of Substance Use and Mental Health. I'm a program administrator for Children's Services. Oh, that's a mouthful.
It is. So Leah will be talking with us in a little bit, and we're so happy she's with us today. Natalie.
I'm Natalie Allen, and I'm the nurse practitioner with Eric's team, the Integrated Services Program, and we're so happy that Amy gets to join us and be our new fearless leader. It's great.
Yes, indeed. And Tina.
Hi, I'm Tina Purcells. I am a parent consultant with Utah Family Voices at the Utah Parent Center. I am also a mom of a 22-year-old awesome young man with lots of challenges. And I also author and review and edit with the Medical Home Portal.
Somebody else with lots and lots of hats. Hopefully she's a little more relaxed. She just had a lovely vacation, I believe. All right, Walt.
Good morning. I'm Walt with Integrated Services Program with Eric's group also, and I'm a care coordinator in the Salt Lake area.
Welcome, Walt. And Tony.
Hi, everyone. My name is Tony Estrada, and I am a care coordinator with Integrated Services Program. That's Eric's team.
Really happy you're with us today. And looks like Whitney Davidson. And I'll just take this moment to say that if you prefer using the chat, you're always welcome to do that. That's always an option if, for instance, unmuting is hard. And looks like that's it. We'll look forward to hearing from Whitney later if that's possible. How about Natalie Carter? Might be the same situation for Natalie, no problem. And then I see somebody who is on a phone with an 801-631 number. And if you are, oh, sorry, Natalie is with the ISP team, Eric Christensen's team, great. And looks like Whitney says hi, wonderful. So if there's someone who is on the phone and wants to unmute and tell us who they are, great. And if they are just on the phone as well as on the computer, we get that. That sometimes happens. Okay, I think that's who I'm seeing on our participant list right now. And rather than take any more time for introductions, we'll just go ahead and get right into our meeting. And if people join late, that's no problem. So best experience typically is on a computer if you're able to do that. Sometimes you're not. And we're going to try and respect your time for sure and end promptly at 10. So with that in mind, let's move to the next slide. I always want to remind you about the Spark Autism Study. This is a very large study. The University of Utah is part of it and very happy to be. It is a research study that is collecting some DNA, but it can all be done from home. And it includes family members of someone with an autism diagnosis, and can include some Amazon gift cards and even some very interesting informational findings that the family can benefit from. So if you have families who are who might be interested, you can get some materials to give to them. and or just pass along the information you have here. And if you want more information, you're very welcome to reach out to me or to Gabby or Heidi. They're helping with that. Just want to remind you about our pediatric project ECHO. This is through the Department of Pediatrics at the University of Utah. Some of my colleagues and myself are involved in this, as is Michelle. Again, we couldn't do it without her. Spring has closed. However, we have a special series that is going on, which is our Autism 101 ECHO series. And we have a couple of sessions coming up there I wanted to make you aware of, including on the 27th of this month, psychiatric co-occurring conditions, and on the 24th of next month, community and family supports. These have been very well attended and they're really interesting. And if you'd like to see any of the past echoes, whether from the regular series or from the autism series, all of those can be accessed via that link. And we'll make sure and send that out in our notes from this meeting. Some updates. We've been working on CPAP and BiPAP therapy for children. We've updated our diagnosis module on Fabry disease, and you may have noticed or not that we've been working really hard on all of the newborn disorders. These are very short informational pages about newborn disorders that are being screened for in many states, including Utah. And we are working to get all of those updated and have an external review on those as well. And they just keep adding more and more, guys. It's very exciting, all the screenings that are now being done or possibly being done for infants. It's terrific. Okay, Athena, I'll hand this one over to you.
Okay, great. And Mindy, actually, you did the hard work of putting this. I put it in a document as well, but we'll go with your version so we don't have to flop between screens. So we are working with a focus on mental health today. We wanted to make you aware of some of the content that's currently being updated and created. And you can see the list there. And then in addition, we have a lot of non-condition specific content on the portal that you can also see listed. And actually, maybe I will take over screen share for just 1 second. I have this all linked in a document too that we'll send out with the resources of the month. So here is the links to all of that content that was just mentioned, and timeframes for when some of this new content will be updated and then when new content will be available. And then in addition, I just wanted to remind you, if sometimes you're having a hard time finding what you're looking for, one of the best ways, because our site is so content rich, is just to search at the top for the topic that you're looking for. And that's going to, this tab is going to show you results from all sections. And if you're like, no, I know it was something really specific to, it was for families, about depression, you can click on the For Families site. That's going to narrow it down even further to just the content in the For Families section. Or if you're like, no, it was actually in the resources section, and that will then, in the resources section, you can look at all the great links we have to PDFs and other websites. Anyway, there's lots of ways to search on the website, so I just kind of wanted to go over that really quick today.
Thanks, Athena. And yeah, the kind of the moral of this section is that we are continuing to put more and more mental health content out there. And please search. And if you're having trouble finding it or need a little help, just reach out to me or Athena, and we'd be happy to try and help you connect with the content that we do have.
I have a quick question. Is this a bad time?
No, go for it.
Athena, I was helping a mom try to locate therapy in a rural area. And when I took her there, I was having a hard time explaining to her, when you go when you're searching for Utah services, there's like term and then category. I couldn't explain to her what the difference was. So can you help me better understand that? So when I'm helping families, I not look like I did the other day.
Yeah, absolutely. So Mindy's got the screen up. So a term is essentially an open-ended search that's going to search names of agents. It's going to look for keywords. Essentially, it's like the equivalent of a keyword search. So it's going to look for that term, whatever word they use. If it's ABA, it's going to look for that in titles of agencies, in descriptions. So it's probably going to produce a lot of results. Where the service category, we try to go ahead and kind of group types of services together. So if you can see, Mindy, if you start to type ABA in the service category, you'll see there's actually a category for that they could just go directly to, and it would show all the listings that are categorized as that service. So both beneficial, but the term might be an easier place to start for some people that are new to, especially a lot of this terminology, like they might not know what ABA is and things like that. So
we weren't getting many results, and I think it is because there actually there wasn't anything available, but I was confused, like, oh, do I have to have a term and a service category? So anyway, that was because we weren't getting much, but I think it's because there just wasn't much available. But anyway, thank you.
Yeah, and in fact, sometimes it's actually, if you're not seeing a lot of search results, it's better to have less in there. This is going to, narrow it by both. They have to have that keyword essentially somewhere in the description plus be in that category. So which you would expect, but maybe not is always the case. So, and this too, Mindy has just circled the show all button. So right now you're just seeing page 1 of results. If you click on show all, you might actually see more map dots than you were seeing previously as well. So great question.
Thank you.
Really good question. Thanks. All right. Okay. Good segue. Great segue into our brainstorming section. So this, as you guys know, is where you get to talk about things that you're having trouble with, new resources. If you've got something to share, we always love hearing that. We make sure those get into the medical home portal services directory we were just looking at. QI stuff, motivational interviewing stuff, all that. This is your time. So I'm going to be quiet, and please feel free to put stuff in the chat or just speak up.
I have a question about a resource. We used to work with Susan Dickinson, who is a psychologist and then would do testing, and she had a program, and it escapes me of the name, but this program would help partner with families for schooling issues, but they also provided small grants to families that had children with special needs that maybe wanted to take swimming lessons that summer, and they would work and pay for the swimming lessons, but they would have some buy-in from the family because the family would need to write letters of support for the child and then follow up on how this impacted, Thank you. Oh my God, thank you, Tony. Are they still doing this, and are they still getting funded? Thank you. That's it.
Okay. Very nice. All right, let me look that up real quick. Able differently. We have that for sure.
I just couldn't think of it. Thank you.
Let's see what we got in here.
So this is Heidi. I am talking as a parent right now, especially. So, and this is maybe actually directed to Tina personally. My son, we're trying to find a job for him. He's very, limited in what he can do and understand and things. I've tried to call Voc Rehab. They have not returned my call. They have not, they've not done much, well, anything at all to help me. Is there something that you can help? And also, he'll be 18 in oh my gosh, he'll be 18 in November.
Okay.
So maybe I need to meet and help with get some, maybe his social security disability going, and also
Heidi, you need to call me. We need to like go over everything to make sure all the bases are covered. So
thank you.
When you have time, I personally, there's 3 of us that can do this stuff. I personally work Tuesday, Wednesday, and Friday.
Okay.
9 to 5. So you can just call the parent center. I am home-based, but I'm linked into everything.
Yeah.
So they'll just like call my line and, you know, transfer you.
Okay.
But find a little time, because all of those things are really important, and I want to make sure that you have everything you need. The voc rehab, I'm not surprised to hear what you're going through with them. It does happen often, but what I always tell parents is, you know, if you're not getting results from the person you're trying to call, then you need to find out who their boss is.
Yeah.
And I don't need to be, you know, jumping the gun so quickly, but if you're not even getting them to pick the phone up, then there's something weird going on.
Yeah, it's like email and phone, and the other thing too is hard with school, right? Because he's back in school, and they were supposed to have voc rehab. Like I signed up, and they were supposed to come and see what he can do and things like that. And I don't feel like that has happened. So that was just my frustration with voc rehab, because in the past I've heard that they've been great, and so I really didn't worry too much when it comes to my personal issues, but now it's becoming very frustrating, to say the very least. So
yeah, and I think, you know, like everything, it boils down to that one professional that is assigned to work with your child. If you haven't gotten to that point yet, it boils down to, you know, but then again, we have a lot added over the last couple of years, like people being out sick a lot, and you know, maybe they don't have enough people working in the office. So we have to take all that into consideration, but definitely voc rehab. And we have other avenues that we can really, you know, look at for like some pre-employment training, things like that.
okay, great. Thank you very much. And sorry to take up some for my
No, that's good though.
Personal issues.
I love how we've got this person just like showing us all the information.
Yes, I know. I'm looking at it, I go, oh my gosh. And this is always a reminder to me too, is that there are things on the medical home portal. You have to look. So thank you, Tina. And thanks UCCCN to help me navigate all of this.
But with this specific transition piece, it's really good for you guys to call us, because we've got several consultants that have actually gone through it themselves. So I can give you that personal, this is what happened with us, and this is how many months, and here's the comparisons. And so, yeah.
That's fantastic.
Yeah.
Thank you so much.
Yep. Anytime.
Good, good. All right. Anybody else?
This is Dora from Shriners Children's. We just have an update. Our providers are now included in the Select health insurance. That's brand new, just so that everyone knows. There's so many great things that are being talked about and between Primary Children's and Shriners, and we will share more as they happen. But there is a lot more collaboration coming, so that's great. We've always taken care of everybody. They take all insurances, Medicaid and uninsured. I know that's one of the things that has concerned some families when the providers refer and it's out of network, because it's scary when you hear out of network, right? They don't know that they'll take care of them regardless if the insurance covers or not. But Select Health is a part of their network now.
Wonderful. Wonderful. Thank you, Dora, for that update. Really appreciate it.
Thank you.
All right, we might have time for one more. Does anybody else have anything else they'd like to share or ask about?
I have a kind of a rabbit trail question regarding the no answering of the phone from Voc Rehab. Our mental health provider down here is Four Corners, so they provide the mental health for our Medicaid. We've tried for 2 days to call. We called 6 times yesterday to try to get into somebody, to get a family in. We called this morning, talked to somebody in real life. We've been happy. And then they gave us another phone number to call, and it's the same thing. They're not answering their phones. And we don't know what to do because we have families that are in crisis or need mental health counseling, and that is who they are supposed to go to as a Medicaid provider. We are told that some providers can see them if Four Corners will sign off on them, but I've never done that before. And if we can't get them to answer the phone, is that something I need to go down in person? Has anybody had any experience with this or have any ideas for me?
So this is Leah with the Office of Substance Use and Mental Health. Can you send me an email or let's connect after this? Because that's a problem. So I'll put my email in chat and my phone number.
Perfect. Thank you.
Thank you, Leah. That's what I love about this group. All right, let's go back to our PowerPoint, and thank you guys so much. It's my favorite part. All right, Michelle, if you will help, we're gonna pop up that survey that I mentioned. I'll stop sharing and let Michelle do that. Great. Okay, we'd love you to fill out this. I think there's 7 questions if you're able.
Mindy, I didn't fill it out because it doesn't.
Absolutely. Doesn't apply to me either. So yeah, I just closed mine. Hopefully that shows up in the, I don't know how that shows on Michelle's side.
Yeah, it doesn't let me know, but we're at 45% participation.
Okay, well, I think I'll go ahead and start the next thing. And if people are still filling that out, that's great. Hopefully this won't disturb them too much. But the next thing that I wanted to show and mention is, and just take a few minutes, is let you listen to a little bit of an article, a story I heard on NPR last Saturday about 988. I think it'll help set the stage a little bit for what we're going to talk about here. So let me get over here and see if I can, hopefully my audio will play. It's about 3.5 minutes. How do I do this?
Beginning today, anyone in the country having a mental health crisis can dial a 3-digit number for help. The new 988 Suicide and Crisis Lifeline replaces the existing 10-digit number and will respond to all mental health emergencies. But as Ritu Chatterjee reports, the number will only be as good as the resources behind it.
Until now, the vast majority of people with mental illness didn't have many choices to get help during crises. Psychologist Ben Miller is president of Wellbeing Trust.
There's really very few options for an individual who's experiencing those crises. They go to the emergency room or they call 911. And both of those are fraught with challenges that rarely end with the individual receiving what they need.
With emergency rooms, it can take hours or even days for someone in a mental health crisis to get help. And 911 often leads to interactions with the police.
Unfortunately, a lot of our police officers, they are not trained in mental health. And so we have unfortunate tragedies that occur because they just simply don't know how to respond to individuals that are experiencing mental health crises.
He says over 2 million people with serious mental illness got booked in jails last year, and about 25% of fatal shootings by the police involved folks with mental illness. People like Miles Hall, a 23-year-old African-American man who was shot by the police in 2019.
He was just a great kid. He was just the kind of, he'd walk in a room and he'd have this infectious smile.
That's Town Hall, Miles's mother. She says Miles was diagnosed with schizoaffective disorder. And one day, back in 2019, when he had a breakdown, the family called 911.
I'm telling them Miles is in a mental health emergency. We need help. We need an ambulance.
And yet her son was shot and killed by the police just outside their house.
I had a false expectation that if law enforcement knew him and they knew he just had a mental health condition, that he would be treated with compassion and he wouldn't be gunned down in the middle of the street on a bright sunny day in our cul-de-sac. There's no reason Miles should have been killed that day.
Paul is among the many mental health advocates who hope that 988 will be a safer, more effective alternative. Angela Kimball is with the advocacy group Inseparable. She says many communities across the country have been adding mental health services in preparation for 988, things like mobile crisis teams.
That's really encouraging news because more and more communities will have that as a potential response, and that makes a huge difference.
And she's personally seen what a difference that can make for families. Back in 2017, her son, who was living in Portland, Oregon, had a major manic episode.
He was talking about how soap was poison and how he felt like he was being surveilled, and then accusing me of conspiring with the government to watch over him.
She says she reached out to a local crisis center who sent a mobile crisis team to her son's house. She says they spoke very gently to her son.
They just said, "Hey, Alex, we hear that you haven't been sleeping for a few days. How are you doing?" He says, "Yeah, I can't go to sleep. You know, my head is hurting and I just want to fall asleep, but I can't."
Kimball says her son willingly went with the team to a crisis stabilization unit and was able to get care right away. Mental health advocates hope that 988 will make that kind of care more common around the country, but it may take a while to get there. Because the nearly 200 local call centers that make up the national network have primarily depended on local and state funding and have been struggling to survive.
Okay, I'll stop there. I just was thinking, oh, wow, well, this will help frame what we're talking about, at least in part in this meeting, and also make sure that you guys are all aware of 988 having been rolled out last Saturday. And we'll learn more and hear more about that, I am sure. So with that as a backdrop, we'll hand the time over to Gabby to bring us up to speed kind of briefly on the SMR program. And Gabby, I'll be happy to advance slides as you're talking.
Oh, I think I would rather do my own slides. I think it's probably quicker. So I assume that everybody can see them by now. So, all right, thanks, Minnie, for giving me the opportunity. So actually, I'm filling in for Heather Shotwell, who is actually really an expert on the SMR program, but unfortunately she cannot make it today. And so I'm going to give a kind of a bird's eye or a very broad overview of the program. But before we go there, I just want to talk a little bit about our mental health in youth in Utah. So here's a 2020 statistic, and Utah ranks 41 in the nation. So states with higher ranking 1 to 13, that tells you there's a lower prevalence rate of mental health and also a better access to mental health. So 41 tells you that, yes, there is probably room for improvement, not probably, but definitely room for improvement. And I just want to say that because of timing questions, we will do them at the end of all the 3 presentations, and then hopefully we can answer some of those. Okay. So Dr. Liu and I thought, so we looked at some statistics from Primary Children's Hospital, ED, and looked at ED admissions due to mental health crises or mental health issues, and how many of those were actually discharged home after the ED visit, and 60% were discharged home. So that begs the question, so why are 60% discharged to home? Is there something or anything the pediatricians, the pediatric office, the care manager, the family could have done to avoid the ED admission? And as we and we just heard in the radio piece over here what Minnie played, that ED admissions for mental health crisis, it's it's very hard on the family. I mean, you're sitting there for 2, 3, 4 hours, and then you're getting sent home. It's sometimes very frustrating. So to answer this question, Dr. Liu and I went around to pediatric offices and tried to identify key drivers. What brings children to the ED with mental health crises? And we talked to Alpine Pediatrics, and I'm glad Angie's on. We talked to Family First, Midtown Primary Care, UVP, and I think we have a care coordinator from UVP on, Wasatch Beach, and We Care. And here are some of the points or bulletin points we heard physicians or providers actually told us, and there were many more. There's just a few of those. And on top of it was pretty much that pediatricians feel uncomfortable making decisions when the family calls in crisis, and the default is to send them to the ED. Then we heard long waiting time to get connected to therapy. And as we know, as as parents ourselves, teens are reluctant to get into therapy. And lack of resources. And crises just happen. ED admission is the next best thing to evaluate. Parents are not confident in keeping their children safe, and again, default is go to the ED. And what we also heard from providers is there's no bidirectional communication between practices and the behavioral health organizations, which can be a big problem, the black box. And we have talked about this in the past too. So that brings me to the Stabilization and Mobile Response Program, the SMR. So there is 2 services. There's the stabilization service, which teaches skills to improve family function, create plans that prepare families for events or prevent future challenges, prevent the need for out-of-home services, and equip families with ongoing resources and support. And then there's the mobile response service. So it minimizes the impact of the challenge on the family, creates safety plans, and connects the family to other helpful resources. So what is the SMR? So it's a partnership within the state of Utah. So the team consists of licensed clinical social workers and bachelor level employees, and they offer 3 types of services or different services. So there's support over the phone to families that are having behavioral challenges. Then the team goes to the family's home and provides support there. They will do a risk assessment, coaching, and do a de-escalation. And then return to the family's home in a high frequency for several weeks, which I thought it's awesome, to provide ongoing support, care management, and connect families to resources. So SMR can be a resource for crises, but it doesn't have to be a crisis. So it can be any event the family finds challenging. For example, you have a 2-year-old and it's in a temper tantrum for over 2 hours, you can call them. Or you have a teenager who absolutely refuses to go to school. Family tries to get him out of bed, try to get him or her dressed and doesn't function. They can call the the SMR team. So the SMR program started out in Salt Lake City, but over the last couple of years, it really has expanded its reach into other counties. And so you can see we have the Piatt County, Wayne County, Sevier County, St. Pete County, Utah County, Wasatch, Salt Lake City. So it's really, really expanding. And maybe later on we can talk to somebody who is in one of those counties and actually has used the SMR or has heard about the SMR, has recommended it to their family and has gotten some feedback, but we will keep this for later on. If you go to the SMR website, you can actually find 2 kind of flyers and you can print them. One is in Spanish, one is in English, and you can give this to the family whom you already know they might, have a challenge in the future, and tell them that it's free to the families. However, it has to be initiated by the families. The SMR team cannot initiate it. It has to be the families. And the number to call is quite big over here. And here would be the website. I'm sure it will be in the resources sent out after the meeting. And please go to that one, or maybe you already have it on your most favorites. And that's really, really, in a nutshell, the SMR team. Thank you for listening, and questions will be later on.
Thank you, Gabby. That's great. Yeah, we'll make sure to follow up at toward the end and take any questions that you have about that program. I really appreciate Gabby taking Heather's spot. It was a little bit last minute that we learned that wasn't going to work for Heather. So, all right, I'm going to share my screen again. Quickly get to the right place. Okay. To navigate technology here. Here we go. All right, and I'll just look at our participants and hope that, yes, we've got Dr. Christy Kleinschmidt with us and Maisie Schiffman, wonderful, both from the Call Up program. We're so happy that you could join us today. And Christy, I'd be delighted to let you have the screen sharing if that's something that's useful, or you can just take it away and talk.
How much time do you want me to talk for?
Got a solid 10 minutes.
Okay. Well, maybe
a little more. Okay.
Maybe I will screen share then if that's okay. I will. I'll try to be brief. It just helps me also stay a little bit on task. So.
Sure.
All right. So, are you guys seeing my slide or the presenter view slides? Okay, great. So Call Up is our statewide psychiatric consultation service for primary care providers that was funded by the Utah State Legislature and then is a partnership between the Department of Substance Abuse and Mental Health and HMHI, the University of Utah Health. And we started right before the pandemic. So our rollout's been a little bit rocky. But so just a little bit of information about phone consultation programs. So they're long-term population health interventions, right? So we're not providing direct services. We're really trying to help take care of this population. And states that have these phone consultation programs actually have shown in parental surveys to have increased perception of access to mental health services. And so just by virtue of having this telephone line that pediatricians or family practice docs can call, parents feel like they have better mental health access where they live. It was designed, I mean, it's been around for decades, but designed to support primary care docs, ideally reduces lag time to initiating treatment, right? Not to get in to see a psychiatrist, but just to have your active treatment that you can start. And then we can really kind of help to triage for appropriate level of care. What we're not, I'm going to talk about our limitations a couple times because I was asked to make sure to speak to those too. And so they're not treatment. So these are not like fast tracks into psychiatry, unfortunately. They still don't, like we can talk about ideal treatment level of care, and it doesn't mean that we can actually find that level of care, unfortunately, that exists. I think, there's a ton of really great programs like SMR is one of and the MCOT teams just trying to really try to enhance all of the spectrum of care for folks. And then they're really not also supposed to replace traditional mental health care, right? We're not co-managed. I mean, we can help sort of support primary care docs in managing difficult conditions, but we're not asking you to like treat schizophrenia and bipolar in your pediatric practice. We're really trying to help give some extra support to at least stabilize that patient or figure out where they should be going. So our hours, I think it's on here somewhere, but so the amount of funding that we got to run this program provides for for psychiatry coverage from noon to 4:30 Monday through Friday. And so we have a psychiatrist sitting by a phone. Seriously, we are sitting by a phone waiting for someone to call us. So it's not like we're like, you're interrupting us. It's not like we're doing other things. We really are just getting paid to answer calls. And so over time, you can see we have had increasing calls. The colors don't mean anything. It's just to differentiate the different ones and look pretty. But so we have increased, but even like on our busiest month, right, 44 calls, we probably have 20 days of the month that we're providing services. And so we have so much more capacity, which is partly why I'm here. Because I mean, please, everybody should be calling us. If we ever get to the point that we're too busy, we will ask the state for more funding. Like this is a service, like the state checks in on us. We provide them documentation of what we've been doing. We talk about like ways to better market, which is, we're trying to get out to all the groups that might have interest in this. But yeah, we have so much more capacity to be doing phone calls. So we do have to collect some data. And I think sometimes this is like a frustrating piece for busy primary care clinicians, because we do have to, collect what type of primary care provider is calling, what county are they calling for, and then just age, gender, race, ethnicity, insurance. It doesn't have to be the actual carrier, but public, private, unfunded, and then the zip code where the patient resides, and then the reason for the consultation. And so this is the information we provide to the state, so we can do some, demographic research about who's actually using our program. And then the state funding for the Call Up program covers all patients that are seeing primary care providers in the state of Utah, ages 0 to 24. And so this is reflective of our population in Utah that has an increased risk of suicide as being the #1 cause of death for this population. We do have adult services. We don't have adult psychiatrists sitting by the phone, but if it's if you have somebody that's seeing somebody greater than 24, please call us as well. We'll connect you with an adult psychiatrist typically it's within 24 business hours. We can give the primary care doc a call back. And so, the other thing that the questions that will come up is, I have like a toddler and sort of stressed out parents. Well, the toddler is your patient. Please call us. We can help give you some guidance about like how to help support the parent. And so it doesn't have to be, the dyad can count as long as your like patient that you're seeing is 0 to 24. So reasons we've had people call, like, this is what I've been thinking. What am I missing? What other diagnoses should I think about? What medicines can I try next? They're having this side effect. Can I try this again? What level of care would be appropriate? Sometimes we just get called like, hey, the parents haven't wanted to see psych. Will you tell us if that's an appropriate referral for us to be making? A second opinion for types of therapy. We can discuss triage. We're not set up to be an acute crisis, right? So if you have somebody in crisis, you should be calling 988 or get your mobile crisis team to the office, like talking, we're happy to give support on the phone, but because we're not physically seeing the patients, it's hard for us to help with those really acute like safety issues. And then seriously, anything else, just give us a call. We are happy, like even like provider well-being, especially the pandemic, we're like, hey, pediatricians, call us. We're happy to just talk through like the challenges that you're having right now. So and any other, like if it's not on this list, we're still happy to call. So there's 2 ways to get a hold of us. The phone line, so 587-3636, and then there's an agent that answers the phone. They get that demographic information, then they connect you to the psychiatrist. It can take like 1 to 3 minutes, and so I think having someone call ahead can be helpful, right? And then hand the phone over to the primary care clinician when they're ready to talk. Or we have a website, and there's an online form, and so you can fill it out anytime. It actually asks those questions that we need. It populates our work queue, and then you can specify what time would make sense for us to call you back. And we try, as long as we're not getting another call at that same time, we try really hard to be very respectful. If a provider says, call me at 1 o'clock on Thursday, we try to call exactly at 1 o'clock on Thursday to get back in touch with them. And then if all you need is resources, you can call that line and just ask that contact center, hey, I am in, San Juan County. I need a anxiety therapist for a 16-year-old who takes United Behavioral Health. Can you please help give me some resources? And you don't have to talk to the psychiatrist for that. The contact center agents can help find those resources for you as well. And just, limitations, I kind of talked to some of these, but just, ideally we'd be open all day, every day, so people can call us when it's most convenient to them. We tried to mostly go over the lunch hour and thought, at least like in the afternoon, patients seen in the morning, we can at least talk to them in the afternoon. We don't have any better way to get into psychiatry. We don't have an in-person evaluation piece right now. We're not for acute crises. We don't talk to families, right? And so we don't have any like direct patient services. And then often, like we can only give a piece of it, families sometimes need like in-home therapy or ABA resources or other therapy things too. And so we're just like one piece of the puzzle for putting together a treatment plan sometimes. And then future plans, we're really trying to get everywhere in the state. We'd love to hit every single, primary care practice that's out there. We are working really hard on an app. So actually you could download the app and we could do asynchronous consultations. And so, the doc could send us a question, we can send it back. We're continuing to do surveys about satisfaction and service expansion if we could. And then we're hoping to have it for all ages in Utah as well. So there's our information. We can put, Maisie, we can put why don't you put the email in the chat too? And then I will stop sharing. And then just the other, sorry, I had one other clarification. It is only for primary care clinicians. And so we have had some like embedded therapists or some like psychiatric nurse practitioners that call. That's not actually what the purpose of this phone consult line is. It's for primary care clinicians, just if the question comes up. And I think it's done.
Christy, thank you so much. Thank you, Maisie, for putting in that information in the chat. Tina Purcells did put a couple of questions in the chat that might be best addressed now. Is this program inclusive of people with intellectual disability, autism spectrum disorder, nonverbal speech impairment, et cetera?
I mean, we can certainly direct, help direct treatment for those populations as well. And then we do have some autism specialists that also consult in this program, and sometimes we'll set that up. That might not be like right in the moment, but we have like a sources of distress scale that we can give the family to fill out. And then typically it's Dr. Builder will give a call back to the pediatrician to kind of talk through that as well. And then, yeah, the resources that we have, probably we have a few more resources than that, don't you think, Maisie? If people would call looking for services, yeah.
Okay. Oh,
thank you. I appreciate that. I always ask because you just never know, and sometimes they just route them back to us at the Utah Parent Center, and it's like, oh, that's where I work, so that doesn't help me. But thank you. I appreciate that, and knowing that you have the scales of distress and stuff like that. That's important. So
yeah, I mean, I would envision, if we get enough utilization, right? Like here, we're just like, please keep us in business. But if we get enough utilization, I'd love to have like, oh, here's the autism route, and oh, here's the like rule out bipolar route. Oh, here's the like, I think with more utilization, we could even have a few like subspecialty type populations.
Yeah, and I'd love to even see you go into the idea of, this person with ID and nonverbal speech impairment is in distress. Why? Do we have a pain scale we can look at? Do we have a, I could think of a lot of things. We could talk a long time.
We certainly could. Thank you so much, Christy. I really appreciate you taking your time, you and Maisie, and joining us this morning. It means a lot, and we definitely want to see the Call Up program be a success. So I'm hopeful that this will help with that, and we will definitely kind of touch again on that at the end of the meeting in our discussion. So, all right, Leah, this is your time, and I'm delighted to turn the screen over to you if that's helpful or whatever works best for you. She's doing it.
Mute. Okay, I think I'm doing a screen share now. Zoom and I have been having some problems this week, to be fully honest. Okay, so again, I'm Leah Colburn with the Office of Substance Use and Mental Health, and I'm just going to go over a quick overview of our public mental health system, but first focus on where the Office of Substance Use and Mental Health now lives. As I think everyone on this call is aware, we've had a merger, and so we moved a little bit. So this is the org chart for DHHS. The Office of Substance Use and Mental Health is now under the Healthcare Administration area under the Division of Integrated Healthcare. And so we fit right in this little bucket here. I don't know if you can see me moving around that with my mouse, but that is where we live now. We did not disappear, we just moved. So just to kind of orient you about our office, again, we're under the Division of Integrated Healthcare, Office of Substance Use and Mental Health. We have operational oversight of the Utah State Hospital, and then we are the single state agency that has statutory oversight of the funding for our local behavioral health authorities. And our local authorities will either provide services in their catchment areas directly, or they'll subcontract. And so, like I said, who are we at the office, which we are kindly calling ourselves awesome. because no other acronym seems to fit and roll off the tongue as well. So we're calling ourselves awesome right now. So again, we're the single state agency for behavioral health. We coordinate with the public funds for mental health and substance use disorder treatment and prevention. So that's the unfunded dollars as well as the Medicaid dollars that rolls out to our local areas. And I will say that this is the legacy Medicaid. This is not necessarily different sources like TAM, which is the targeted adult Medicaid, or things of that nature. That's a whole nother pot that we will not have time to go into. So our role at the office is to really ensure that evidence-based best practices are used in our community through our local authorities. And we do that by a number of ways. We have contracts with them, division directives, there's statutory requirements that our locals need to do. And we really monitor that. I think it's important to remember that we at our office do not provide direct services at all. We are more behind the scenes and having those conversations, which is why, I said when there is an issue with Four Corners, please reach out to me and we can problem solve that out. Our scope of responsibility at our office is ensure that prevention and treatment services for substance use and mental health are available. We contract with county governments, provide that oversight, monitor, evaluate behavioral health services through our annual reviews. We provide technical assistance and training to our local authorities. We evaluate the effectiveness of prevention and treatment programs in the state. We communicate our results to stakeholders. All of our reports are available on our our office website. And like I said, operation of the state hospital. So just kind of as we're talking more specifically about children, youth, and families, my team, which is the Children, Youth, and Family team, has a few initiatives that we are focused on. That's not to say that we are not focused on the overall mental health access of kids and families in our state, but these are some of the initiatives that we're focusing in on right now. Family peer support is one of them. Our family peer support system had a little change with the closure of one of the main agencies who provides that. So we're in the process right now of rebuilding family peer support, recognizing that that is a very key service that needs to be available in our state for children and families. School-based behavioral health services. Our local authorities partner with local education association or agencies, LEAs, to provide on-site school mental health. And to kind of just speak to the difference of what our local agencies provide, that is on-site clinical mental health services versus in the schools they're providing non-clinical mental health services. Early childhood mental health, we're very focused on workforce development and really helping build out that infrastructure to ensure that kids from birth to 6 years old have access to quality mental health services, recognizing that that's a really key time for intervention. We recently hired, I'd probably say in February or March, a person whose sole focus and responsibility is intellectual developmental disabilities and mental health. We know that that's a huge gap in our states, and her primary responsibility is to look at how we can close that gap within our local authority areas related to training, workforce capacity, and ensuring greater access for the co-occurring disorders. Prevention-oriented work. We have a team solely dedicated on youth in transition, while their focus really is on a few key areas in the state based on their grants. They are trying to work to better that transition process from youth to adulthood, and making that a smoother transition for the youth, providers, and their families. That group also has the first episode psychosis programs, which are grant-based, and they are available in Davis County through Davis Behavioral Health, Utah County through Wasatch Behavioral Health, and Weber County through Weber Human Services. And those are really great early intervention programs that are very robust as people are young people are identified with their first episode psychosis. Again, that ongoing partnerships and collaborations, and then utilizing the full continuum of care, which I'll talk about in a few slides to help really to help with those health disparities across our state. So this is just a map of our local authorities. We have 14 local authorities statewide. As you can see on this, they cover the entire state, rural frontier, et cetera. All of our local authorities, like I said, they can either provide direct services or many of them will contract with independent providers. So Summit County, Salt Lake County, and Tooele County have more of a contracted model. So they don't have one agency providing behavioral health services in their area. So that's why, you know, in Salt Lake County, well, not that's why, but in Salt Lake and Tooele County, Optum Healthcare oversees that contract, which is why they have a wider network of providers in their catchment areas, just as in Summit County, DU Healthcare is overseeing that contract via Summit County. So access to services, and I know that this is really kind of, you know, the meat of things. Like I said, our local authorities, they provide services to our Medicaid folks in our state, and they operate under the capitated mental health system, which is the PMHPs. Wasatch County, which is Heber. I always confuse that, but Wasatch County, Heber, and Bear River Health Department, which provides the substance use treatments, are fee-for-service Medicaid, which is a little different, but it doesn't really change how a person accesses services there. Medicaid members must obtain inpatient and outpatient mental health services through their PMHP, unless that person is contracting out. And again, Medicaid members are enrolled with the county of their residence. There are some caveats if, you know, that local doesn't have that service and they've contracted with a different area. So like residential is a really good example. That person might be receiving services outside of their county based on a contract. Some of our local areas are accepting commercial insurance. That kind of depends on their capacity and really what they've set up in their area. But across the Wasatch Front, many of the providers do accept commercial insurance. And I'll just touch really lightly on the DCFS Medicaid insurance, specifically the carve out for those youth who are post-adopt or post-adopted. So a person who has been adopted in our state, they have an option to have insurance, Medicaid insurance that can either be carved into our local mental health authority system, so they receive services through that local, or they can carve out and access contracts that DCFS has specifically for Medicaid. If you have questions on that, please let me know. It's kind of a complicated system, but the idea about that is that those youth have, as well as kids in DCFS custody, have more options when it comes to services. It kind of gets complicated on many levels, but that is an option that's available. So if you're trying to find out which is your local authority and how to access services, a person can go to our office's website, which is still our old email link or old URL, choose on the county treatment authorities. You can type in your county and you'll get the contact information for the area that you're seeking services in. So I'm going to spend a little bit of time on these sites specifically. These are the mental health continuum services in our state. These are the mandated services that all local authorities either need to provide or have contracts to provide in their area. I will say that all of these services are based on medical necessity and clinical need. It's not one of those, I just want to walk up and say, I would like to go to residential. But this is based on medical and clinical necessity. So all of our local areas are required to do the payment for acute inpatient, and that doesn't matter if a person is in their parental custody, if they're post-adopt, or if they're in DCFS custody. Our locals oversee all inpatient stays on Medicaid. Residential care is another one that most of our areas actually contract with. There are very few mental health residentials in our state, especially who will accept Medicaid and the requirements for Medicaid. So residential is few and far between, but there are a few out there. I will say that because most of them are contracted, they're independent agencies, not associated with our locals, and they kind of have a window when it comes to what presentations and what mental health diagnoses that they will take. All of our locals provide outpatient care. This can look a little bit different depending on the area, but all of them will provide either telehealth or face-to-face traditional individual and family psychotherapy. Many of them have intensive outpatient or day treatment programs or after-school programs as well. All of them, like you're talking about before, when you're talking about 988, all of them have some sort of 24-hour emergency crisis care. A lot of that is run through their MCAT or mobile crisis response teams. All of our areas do have crisis response teams up and running, and they can respond to crises in their community. They all provide medication management. This is done through either having a psychiatrist on staff or a APRN. Some of them do access some telehealth in their area to help kind of close that gap when it comes to medication management. They provide psychosocial rehabilitation and skills development. If for kids, that often looks like, group skills, day treatment skills, individual skills, case management, community supports. For kids, that really looks a lot like that family peer support services and respite care. And respite care, it really depends on the area that you're in. Some of them provide individual respite. Some of them have crisis receiving centers. That's how they run their respite programs. It's really area dependent. They all are required to engage in case consultation, collaboration with other state agencies and public education. And then for adults, they are required to provide services in county jail facilities. And this continuum, I will say, while I talked about it with the youth lens, this is also required on the adult side as well. These services, there's just a little bit here and there that are different. And again, this is all based on that medical necessity. And really, I think it's important to remember with our local authorities that they are treating the mental health diagnosis for a person who comes in. I know oftentimes I've heard in many other meetings, and kind of this has been hinted at in earlier, when a family sometimes families hear, well, they don't treat autism. That is correct. They don't treat the autism, but they can treat the anxiety, the depression, the co-occurring mental health side of that person's autism, and therefore that co-occurring disorder. Any questions? That was a lot of information. I can talk for days, but 10 minutes.
Yeah, I have questions. I'm sorry, you guys. This is going to be, I feel like this whole day is just talking to me. We are getting challenged in the integrated services program with mental health is becoming huge, and they're hard cases. We spend 2 or 3 or 4 of us can spend entire week working on one child. So Leah, I don't think you can answer all my questions, but what I'm asking is, because a lot of the clients that I see are in rural areas, your presentation is beautiful. We sometimes feel like we get stuck in all of that. And I'm not sure if it's because we're approaching the wrong people or contacting the wrong people, but could I call you and maybe we could chat and see? I'm thinking of a particular child down in Richfield currently. So I just really struggle because everything that you're talking about, I'm like, yes, this should work for us, but it's not working for us. And so can you help me?
Yes, that was the questions part of I'm available. Yes, so please just call and set up a time to chat. I think that, like all of us, and not particularly, I say us as the global mental health workforce, right? We have all experienced some great challenges over these past 2 years. And I will be the first to say, our local authorities really are trying the best that they can. Some of them are experiencing some great workforce shortages that have not been able to be rectified over these past 2 years plus. So yeah, please reach out. My email and phone number is in the chat, and we can just, chat about cases. I'm always available for case staffings. I think I've talked to a couple people on this call about some kids at some time, one point or another. I'm always available for case staffings, or even just that warm handoff to one of our children's directors in the area. I think that one of the things that I always recommend when it's working with our local authorities is having that warm connection, because oftentimes, and this isn't always the best, but sometimes just being able to know who to talk to, and it's not the front desk receptionist, helps. So especially if you're doing that professional kind of case staffing.
Thank you.
Hey, Leah, this is Heidi Bates.
Hi, Heidi.
Hi. We were, UPIC was involved with a quality improvement initiative with behavioral health organizations. So Gabby was wonderful and did all the providers, and I took on the behavioral health organizations. And one organization, the juvenile justice system, they joined. Their frustration was that when they call MCOT, because juvenile, and I had no idea that, like, behavioral health world was very new to me because I'm very clinical. They thought that they don't have any clinicians there, right? Most of it is like they have the Gemstone program that serves the LGBTQ. There are a lot of day programs, but they don't have somebody there to help in a crisis. They're there for other reasons. They got, they're in trouble, they're being exploited, things like that. So when a patient or one of their kiddos becomes actively in crisis, they will call MCOT, and they said that MCOT will come out, but very rarely will they transport them. And so if it's all right, we were trying to figure out who to call to try and meet to talk about the MCOT process and try to make it a little bit because I think it came across as the juvenile justice system didn't understand what MCOT does, and MCOT probably doesn't understand the dynamic of the juvenile justice system. And so they
had some additional conversations since that was first brought up with JJS and MCOT and such. I know Amanda Elkema was working on that a bit.
Okay, that was just.
Yeah, and I think it's also important to remember just in general for folks here, right? Like the idea with MCOT and that mobile crisis outreach is that's an intervention, right? So calling the crisis line is an intervention.
Yes.
Having it determined that someone needs to come out is an intervention. And I think it's also one of those things where I think the community sometimes gets frustrated. I know when I was a clinician many years ago and MCOT started, right? Like I would get frustrated. My assumption was that MCOT would come out and take my kid and put them in acute care, right? And so I think that it's also this idea of MCOT. The idea with MCOT is to be able to see if they can do an intervention, a safety plan in the community, and have that person, if it's safe, remain in the community, and then receive those follow-up services as well. And so I think there's that part, right? It's a continued process, but I do know that JJS and MCOT have had some additional understanding each other's systems conversations.
Right. Yeah, and that's all that because again, I am not an expert in the behavioral health world, right? I'm a nurse by trade, and I'm very clinical things, and MCOT, as a care manager, I have given the MCOT information to parents for their child. I just, it was just another opportunity, to be like, maybe we should open up these dialogues to understand what JJS does, because I had no idea what they did. I thought that they were a lockdown. They had 24/7 clinicians, they had, they had everything. I had no idea that that's not how they work. And on the same thing, I think that they need to also understand how MCOT works, because they have a total, a different idea of what they do. So that was just my
100%. Like, I am the biggest fan of systems, understanding what systems do.
Yes.
Even as much as, you guys talked a little bit about 988, like maybe in a future meeting, I can have someone from our crisis team come and talk a little bit more deeply about 988. Because fun fact, the idea behind 988 was started here in Utah by two of our state legislators. And so there's a lot to, I think all of our systems as a whole, and I'm the biggest fan of just having those conversations and getting the information out, and how do we bust down some barriers to support that.
Yeah, and I think, and that's what I call, as I was talking and working with JJS, I think we need to understand that the most important person is the patient, right? It doesn't, that has always been my passion, is just for these kids that are in crisis, struggling. And so when I joined these, when I help lead these processes, my first thought is always, how is this going to help the patient? What can we do to help the clinician? What can we help, to help the organization? But more importantly, how is this going to help the kid in crisis? So so that's where I'm coming from. I just, I'm hoping that they're still in talks. I haven't been in contact with JJS for about a month or two, just because the collaboration ended. But I just wanted to, bring that up. But thank you so much for all that you do, Leah. I really appreciate you.
Thanks, Heidi.
Thanks, Heidi. Okay, we wanted to keep a few minutes for some discussion by the group to kind of tie that survey and some ideas around screening back to the presentations that we've seen. Does anyone else have a specific question for Chris about call up, for Leah about the services that she's described, or for Gabby about SMR? Okay, hearing none, just also know that we'll make sure that contact information for each of those programs goes out with the summary of the meeting. And you're always welcome to follow up, both with the folks who have been on presenting today, or with me, and we'll make sure that questions get passed along. But I definitely want to take advantage of the fact that we have Dr. Kleinschmidt with us, and Leah, and yes, Leah is awesome. So I'll just pop my PowerPoint up again here. But basically, we just wanted to remind you about that survey. So we love to collect baseline information, of course, and then follow up and see if anything's changed. And so while the survey was a little bit more about screening and also trauma, we wanted to try and tie those things back together, because we had a really interesting conversation around the planning of this meeting about do screeners really ultimately help? Do they help, avoid the crisis, avoid the need for an intervention, avoid the need for what feels like a very urgent call to call up, those kinds of things. And so I'd love to have some conversation around that by any and all.
And I think, another part of that conversation is too, that what do you do with results of a screen if you net some sort of, I don't know how to say it, like positive or negative result on it, like something that would prompt you to maybe say, we would like to do something, or we're concerned that there might be an issue with the family that we're working with, or the child or youth that we're working with.
And again, Mindy, it drives diagnosis and treatment, right? So if you're screening somebody and the parent comes in, they're concerned about autism, and you forget to do a trauma screener, this child's showing autism and anxiety, and we miss that there's all this trauma. Like, it really does drive diagnosis as well as treatment, even referral.
And so if you do the screeners and you fit that into your already packed, overwhelmed schedule, and that does come up, what happens when there aren't the resources there to connect them to. And no judgment, no finger pointing whatsoever, because we do understand what a terrible situation so many organizations are having right now with staffing and everything else. But yeah.
Okay, so I feel like this is all about me and my family, Mindy. I don't know. I am being a little loud today. I'm gonna just give me a minute. I'm gonna shut the door because I'm gonna talk about something. So all of you know, most of you know that I have a son on the spectrum, and when you have I don't know, when you have a child that's you're focusing on and you're watching these behaviors, and this goes back to siblings that have, you know, that are siblings that have special needs siblings. You kind of not forget about the other child, but you're not really in tune to what that other child is feeling, thinking, whatever. So you take them to the doctor's appointment and they do the screener, and the screener says that they're fine. They're, you know, maybe at one point they're fine, they're happy, they have no worries at the point. I guess the screener would be negative, right? However, let's say 6 months later, you start to notice these things. You start to notice like, oh my gosh, you know, this is happening, this is there. And then you take them back, you get an appointment, and then all of a sudden the screener is completely, we're in crisis mode now. We're in crisis mode, and the doctor's like, wow, we didn't see this 6 months ago. We didn't, I just want to get, I'm just, and it's my daughter, like she's better now, but we did have a little 2-month stint there that was a little ER visits, you know, uni, all of this stuff. But I always wonder, yes, I know that the screeners can lead to diagnosis, because that's how we, you know, diagnosed my son with autism, and now my daughter with anxiety and depression. But in reality, I guess I'm not, I don't know. I guess I don't feel like maybe the screeners work to help indicate crises. And what about if they do, let's say that the screener it showed medium. Oh my gosh, I only have 2 minutes, sorry. It showed like maybe there might be something there. What, as a parent, because that was another issue, is like, yeah, maybe there's something there, and the doctor's like, are you okay? Are you thinking? And they're like, no, I'm fine, I'm just sad. But then the doctor was like, well, okay, then call me if there's a crisis. I guess I don't know. As our discussion, I don't know if to me, screeners really help look forward, right, to crises and that. I just want to hit it before the crisis hits, and I'm not sure how to do that, I guess is what I'm saying.
And with 1 minute left, I'm not sure that we're going to have a magic answer.
Right, I know.
or with 1 million minutes left.
Right.
Yeah.
But just a thought out there to maybe people that are listening, and to doctors, or, you know, just how does that really help drive care? There, that's my 2 cents.
Can I add just a quick thought? I know we're out of time. This is Angie from Alpine Pediatrics, but as I'm listening to the screener discussion, I mean, Heidi, you're completely correct. You know, so many times for parents, the answers feel unsatisfactory when they're in crisis and they're scared and worried about what's happening with their kiddo. But if a practice is going to offer screeners, and there are a lot of different screener tools out there, you've got to be prepared to react with a meaningful intervention or answer for the parent. And I think that's where, you know, all of us have to be prepared to do that in our own settings, you know, because just having the screener and then not being able to take next steps is not helpful to a parent. And really further discouraging in a really high stress time.
Absolutely.
Yeah.
Thank you for acknowledging that, because that's what I felt. I felt like,
Of
great,
course.
we did the screener and it was medium, but what do we do now in the meantime? Because we kind of know it.
That's
the
just
chances
it.
of it going into crisis are high. However, we were not giving anything in the meantime. Sorry, my dog.
Yep. Just the screener is simply not enough. It's a great tool, whatever it is you're choosing to use, but you've got to have what's next. What now?
Right. Oh my gosh. Eric just mentioned that we'll talk in our planning committee about a follow-up. I think it's warranted for sure. And I love the idea, Leah, of really understanding all of the systems, and how they interact and what all the options are. So thanks, Eric. It's time, 10:01. Thank you to everyone so much. I'm going to, thank you, Christy. I'm going to mention just a couple of things, but if you have to drop off, I totally understand. And I'll take this moment to just thank again those who came on to present. Really appreciate Christy and Maisie from Call Up. Really appreciate Leah. I know you must be so busy right now, Leah. And we'll definitely have more information about the Stabilization and Mobile Response program to make sure everyone is aware of that as well. So thanks, everyone. I'm just going to mention to you really quick 2 things for those of you who have the ability to stay on, as well as letting you know about next month. Thing one is our dear friend Pat Rowe has retired. I'm going to miss her so much. A lot of people piped in on our listserv with lovely thoughts about her. I don't know how to get those to her. She had her email at Select Health bounced back before June 30th. So if anybody knows how I can get to her via personal email or whatever, I would sure appreciate that.
I know where she lives.
Ooh, that's great.
She lives right around the corner from me.
Okay, fantastic. That would be super helpful. And then the other thing, I don't know if any of you guys remember Noemi Gay. She used to be a care coordinator. I can't remember who she was with, maybe Utah Valley. Maybe Wasatch, probably Wasatch. Anyway, she was just really a lovely human being. And then we didn't see her again for years and years and years. Well, I just saw a poster of her at Intermountain's Salt Lake Clinic. She's a DNP in internal medicine there. So I thought that was really cool. I wanted to pass along that. And she's got, I guess, a specialty for the LGBTQ population. So it's pretty cool to see some of the things that our former members are doing. And big, huge thanks to all of you for everything that you're doing. It is a hard time, harder probably than it's ever been. And love to see you on here. Love this community, and go forth and do your good works. Take care, everyone. Hope to see you next month.
Thanks, Mindy. Bye, guys.
Bye, guys.